This is a short video just to explain as a physiotherapist how I would treat somebody with a low back problem, with a pelvis issue, with sciatica, with low back pain just on its own, or with all of those all together. The assessment techniques, the sort of things we're looking at, and then some of the treatment techniques we might employ. We are Witty, Pask and Buckingham, Chartered Physiotherapists in Northampton. We have been the leading physiotherapy clinic in the region for 40 years. We treat bone, joint, muscle, tendon, ligament and nerve issues all over the body. Using manual and manipulative treatment techniques, shockwave and exercise regimes, we work to get you back to full health as quickly as possible. Having sat down with you for 10-15 minutes and gone through the whole history, which can be quite extensive or they can be just an acute onset relatively recently, and ask you lots of questions about the type of pain, where it is, how it presents, and then any medical history and family history you may have of that, images, pictures, that whole picture that comes with that. We'll then get on to assessing it, and that's how you move, seeing how you move, what happens when you move into different positions, the symptoms you get, and that all just builds a picture of you and your back problem. So we'd start off in standing, and I'm just looking initially at the shape of the back, whether we've got any curves, scoliosis, whether we've got very much of a lordosis, an arch back, whether it's relatively flat, whether there's any visible spasm going on there, lots and lots of muscle tightness. We just look at that initially. I'd then ask the patient to curl forwards and just watching very gently. I'm just watching where the movement occurs. I'll talk through this as if it's got a back problem. I'm going to sort of say, well, as you go forward there, Charlotte, again, we've just got some tightness. I can see that this part through here isn't moving as well. And you may say, yeah, I'm starting to get some pain at this point. As you come back up, I'll then say, right, run your left hand down to your knee. And again, I'm just watching to see how this opens up, how it all moves through there the other way for me. And you may go, oh yeah, that's actually a bit sorer there. And you could see that sometimes you've got a block at that point. I'll then ask you to arch backwards, lean backwards, and you'll go, no, that's a bit sore. And if we then drop over and into this corner, you may say, yeah, that's actually a bit more sore than perhaps if you go over to the left. So all of these things tell me about what type of problem we've got. I'll then look down at the pelvis, and I'm going to feel onto the bony points here. And I'll start to lift her right knee to the chest. And I'm just looking at movement patterns again. What happens when we lift up? And lift your left knee up. And I'm just watching to see how all this moves in and through. And there's a few more clues that come from that. Then we'd move on to things onto the bed and how we look at the nerves and the neural system on from there. Now we're onto the bed, we're going to look at the neural system. We're going to look at a few tests that tell us where the symptoms may be, which part of the nerve are affected, and more importantly, which part of the back that is causing some of these symptoms. If it's just back pain, we may not bother to look at these, but it's good practice to go through it nonetheless. So straight leg raise is a test whereby we're just looking at the mobility of the nerve as it runs down through the leg, which can be compromised by compression of the disc or compression of the bones down onto the nerve into the back, but also muscles as they come down through the leg. And all you do on it is you're looking at what happens when you bring the leg up and into the air, and then what happens when you bring the foot up into this position here, which often increases the symptoms. I'm feeling for the elasticity of it, and then one that's affected, say on this leg, it may well feel that I'm starting to stretch a tight elastic band on here, certainly in comparison to the other leg. Now, normal range is around 80-90 degrees like that, and that's perfectly good through there. But if you're then doing this one and it's getting sticky, we're starting to think, okay, that nerve is being compromised. Three other tests that we would do following on from that are myotomes, dermatomes and reflexes. Myotomes are muscles, and when nerves are compressed or compromised as they are with back problems, you have they affect the way in which the messages get down to the muscles. Dermatomes are to do with areas of the skin, and different nerve roots have different areas of the skin and different muscles which they supply. So simple ones, we would just look at different areas. Does that feel same or different? either side as you're running down. Does that feel same or different? There are different areas on the leg, and it's a very simple touch thing. You can get much more complex with it, with various different, if you're looking at very specific things, but really just looking for gross differences in areas of the skin. So that's a simple question and answer session between you and the patient. Same with muscle testing, and you would look particularly at with the low back, lumbar spine stuff, you'd be looking at, hold the foot up there for me. Does that have the same strength as that through the foot and through the big toe? Hold the big toe up for me. Does that have the same resistance as that? And when you've got a lot of neurocompromise, one side will feel significantly different. There are lots of other ones in terms of foot in and out and knee tests for different sections, but that's the essence of it, and we'd run through those. Finally, the classic reflex test is a one that you would just normally do in this sort of position and just see if there's a decent reflex as it into there. Sometimes you'll do also ankle reflex in the same way. All of those just give us an indication of which section and which part of the spine and which nerves therefore are affected and where to help direct our treatment. Once we've gone through the neural test and we've got that information, we'll then look at how the spine feels, and we poke and prod around either side of the spine, find out which sections are painful, which sections feel tight, which sections feel in spasm, and then help to build again more information for ourselves. So in line, face down, I like to have the back slightly flexed over personally, and I'm just looking at how the lumbar spine feels. So that starts from top of pelvis here, straight across. You're bringing yourself onto just the gap between L4 and L5. So you'll just locate onto there, and you're just feeling how the movement is. And it should have a bit of spring, it should have a bit of give centrally, and then off to the side. And off to the side of the spinous processes, I'm just feeling for spasm, like real tension in the muscle. I'm also feeling for tightness, which is not a nervy, spasmy thing, which has almost a rubber feel to it. I'm looking for just general stiffness and immobility in the tissues, and there's a little bit of that into there. But particularly if we've got sciatica, and we've been talking about potentially a sciatica down this side, you may well also have a very sore and painful segment in there, and that will hopefully relate to all the other tests and signs that you've found. So once you go all the way up and down that, and I'll usually go all the way up to the base part of the ribs, first couple into there, and just see how all that feels. I then feel down over the sacroiliac joint, which is just below the line of that pelvis, those two sort of dimples in the back part of the pelvis. Not often sensitive or painful, although they can be, and that would relate to any other sacroiliac joint tests that I have done, which I've not covered so far in this video. And I then feel again where the nerve, so the nerve comes out from the spine here, runs on the inside of the pelvis, and then exits to go off down the leg. We're talking the sciatic nerve here, that runs deep through those glute muscles in there, and that again will be really quite tight and quite tender compared to the other side, is somebody with a sciatica down through there. And so again, that may well be areas that we need to treat for that muscle tightness. So from the assessment, we've decided, or I've decided, that we have a segment in the back, the base part of the back, L4, 5 and S1, those bottom two joints as they attach down onto the pelvis, which are particularly stiff. They've got some inflammation in the facet joints, and that's irritating the nerve and irritating potentially a little bit of a disc. We don't think it's too bad. It's a very classic presentation, but the way we're going to treat it, we found these very stiff segments in here, so we're going to mobilize, potentially manipulate, but mobilize those joints out. We're going to get into the muscles initially, because that spasm around it that is holding onto it is really quite tight, and that's not going to allow me to get into the joints. We're then going to work into the nerve as it comes down through the glute here, and we're going to potentially then work on getting this part of the back really flexed and opened out. So we need to get the muscles first, get rid of all that spasm to allow us to get into the joints from there. The way we're going to start that is in side line. I'm just going to get into, so I'm opening the spine out, we've got a little bit of side flex into there. I'm just going to work thumbs into that tight tissue here. So I'm holding the pelvis down there, and I'm just going to work through, just easing that out. It's one of those things that when the back has been stiff for a long time, is almost like it's scratching the itch. It's in that area you want to get. It feels tight, it feels stiff, and it's kind of initially a very nice relieving feel to it through there. And we'll do that for a couple of minutes until we're happy that we're starting to get that stretched out. We then will work into the glute. Now, I can do this in several different directions. If you really wanted to get it on stretch, I'll bring it round here. So we'll get into that nerve from right into that groove, just the bottom part of the pelvis, just tucked into there, and the nerve will come through. Now, with somebody with a sciatica that's been there for a while, that can be quite a sensitive area, can be quite an irritated part of the joint, so you would be very careful just to build your way into that. And those muscles in that deep part of the glute there are all very stiff and very tight. So we would just work through and into there very carefully. And there's a couple of different ways in which you might do that. So once we've mobilized out the soft tissue, we've got the muscle spasm released off some and into the glute, we then look to mobilize the actual lumbar spine itself, and focusing in as we are on this particular case in these bottom two joints, we would look to rotate the spine. And the way to do that is to centralize it so that we're focusing the movement to those bottom two joints. Reach your arm to my shoulder there. By taking this up very carefully, just taking the tension up into that position and just blocking on the section above that we don't want to move, and just taking that over. And initially you just ease into the tension. Sometimes you can get little clicks going on as you're opening up some of those little facet joints, and you just mobilize the back. A further nice mobilization technique to open the lumbar spine out into flexion is called a nags and snags technique. And we use a belt which sits around Charlotte here, fixing over the pelvis. That goes around me and fixes all the way around. So I've got control, so Charlotte's not going to fall off the bed. And we're just asking now just to curl forwards, and you're just opening up through the lumbar spine. Now got a little bit of pressure on those spinous processes, and we just go not into any pain, but we're just easing, sliding and gliding those facet joints, opening the lumbar spine there. Again, when you've got a very stiff lumbar spine, this is one of those that really feels quite pleasant. It's one of those sort of nice mobilizing, stretching out, easing the tension, easing the compression type of techniques. To finish off any treatment session, you need to go away with exercises and work to do yourselves at home or in the gym that keeps that mobility going, and also looks at some of the reasons behind why that part of the spine may well have got tight to begin with, and that's often down to lack of core control and abdominal strength, and your ability to stabilize and control your pelvis and your spine from there. As there are a number of different exercises, I'm not going to go through all of them. I'm just going to give a simple example, which in this position would be to work on the rotation, if that was the one I want, for you to just stay on the back there with the shoulders, get the hip well underneath you, take hand over there, and you just ease that over into the stiffness yourself. You may lay on the side of the sofa. It may be something you get somebody to perhaps give you a hand with very generally through there, just to mobilize that area in the lumbar spine just into that stiffness. And you can be doing that several times in the day. If you lay onto your back now, again, so many different abdominal exercises. An initial one that we would perhaps start with if you're particularly weak around this area and didn't have a lot of control or understanding of where these muscles were working from, would be a very simple, how do you engage the right muscles in the right place? And that would be just to get you to put fingers just inside your hip bones, tighten up through your lumbar spine there, lumbar spine into your abdominals there, just tensing up into that area, and then say, right, lift your knee to my hand, hold that one there, keep this controlled, keep breathing, don't flatten down through the back, don't allow your back to arch. Now lift this knee up to hand, no doming going on, just keep this same contraction through there. And you can add all sorts of variants onto that in terms of you then allowing one leg out straight and starting to increase the loading, increasing the control that's required around the spine. So many different things. There's an overview of how a physiotherapist would assess the spine, some of the treatment techniques we have at our disposal, and some of the exercises you might want to go away. And it's an overview. Everybody is individual. Everybody would be assessed as an individual, and every treatment tailored to the individual and their particular problems. But that gives an idea of what to expect if and when you come and see a chartered physiotherapist with your lumbar spine problem. Thank you for listening.